This webinar is Compliance with Patient Safety Requirements. I'm David Brushwood with the University of Florida College of Pharmacy. We have three learning objectives that we'll be meeting with this webinar. First, we'll discuss the threats to quality that are present in pharmacy practice environments. Second, we'll list strategies that can be undertaken within systems that detect and absorb pharmacy errors before harm occurs to patients. And third, we'll describe appropriate compliance with the regulatory imperative to develop continuous quality improvement systems at pharmacy practice sites. The patient safety movement has existed for many years, but it received a stimulus in 1999 when the Institute of Medicine issued its report called To Err is Human, Building a Safer Health System. And ever since then, over the last decade and a half almost, we have had an emphasis on patient safety within just about everything we do in healthcare. Among other things, the IOM report suggested that between 44,000 and 98,000 people die in hospitals each year due to preventable medical errors. They actually have data on hospital-based deaths from errors. The speculation is that within the community setting, the number is far higher than that, but since the community setting is much more difficult to observe and to measure, the number is really not very well known. Suffice to say, there are a lot of people who die as a result of medical error, and those errors oftentimes are preventable. Now, the IOM report also recognizes that there's always risk in healthcare. In fact, the responsibility of healthcare institutions and healthcare professionals is to place patients at risk. That's what healthcare procedures do. That's what drug therapy does. If you're not placing patients at risk, then you're not doing your job. But it has to be controlled risks, measured risks, intelligent risks, balanced risks. So the IOM report is suggesting that greater steps be taken toward patient safety so that although patients continue to benefit from drug therapy and other medical procedures, the risks are minimized. The IOM report is also interesting, particularly to those of us in pharmacy, because they emphasize medication error as an area of concern. And I will confess to you that reading it the first time, I thought, why are they picking on us? Why is there so much data in this report related to medication error, as opposed to diagnostic error and treatment error and procedural error and the other kinds of errors that certainly occur, but aren't the focus of the IOM report the way medication error is? And finally, I figured out a couple of reasons. First of all, medication errors are detectable. You can see them. It's really easy to see. When a green tablet is prescribed and a pink capsule is dispensed and administered, you can see that. You can detect it. When a medical procedure is undertaken and something goes wrong, it's harder to see that that has happened. But with medication error, it's detectable. A second factor, I think, for this emphasis on medication error is that they are preventable. It seems so easy. It just seems so simple. The patient needs a green tablet. Get the green tablet. Don't reach for the pink capsule. It's easy. It's so preventable. Other types of medical procedures just seem far more esoteric, difficult to understand, and more forgivable. But the medication error is less likely to be forgiven because of its simplicity or perceived simplicity. Another important aspect of the 1999 IOM report was the conclusion that it's systems that cause errors to occur. It's systems that set up people to err. Requiring system change requires changing culture. So you can't require system change without establishing a culture of safety. And finally, changing culture within a practice site requires an environment of trust. It takes people who've been there for a while, who are familiar, who are trusted to facilitate a change. This is not something that can come from the top down. It's something that has to be done bottom up and locally. Now, this commitment to patient safety that's existed for the last decade and a half is a party that everybody's invited to and everybody's shown up. So there are all sorts of interests that are represented from the regulatory community in the patient safety movement. The FDA is there. The FDA realizes that they approve drugs that have names that are similar to and can be confused with other drugs. They're trying to work on that so that the names of new products aren't so easily confused with the names of existing products. They look alike and they sound alike, and they're trying to change that. They're trying to change the packaging. Trying to change the packaging so that there are aspects of the packaging that prevent errors from occurring, so that similarities are de-emphasized, so that there are actions that have to be taken in opening a package, for example, that reduce the likelihood of error. FDA has its REMS programs. This, rather than being single product directed, is more global than that. REMS programs are implemented to promote patient safety throughout the use of a medication. The DEA has a commitment to patient safety. There's a corresponding responsibility that the pharmacist has to assure that a medication, a controlled substance, has been prescribed for a legitimate medical purpose and in the usual course of professional practice. And then there's upstream surveillance. Pharmacists are surveilled by wholesalers. Wholesalers are surveilled by manufacturers. So DEA has this commitment to patient safety. There's some problems with the way that's being done, but one good aspect of that is that everybody shares responsibility rather than focusing the responsibility on the pharmacist. Educators have a commitment to patient safety. In the initial training of pharmacists and technicians, patient safety principles are taught. And in continuing education, there are consistently programs offered that help pharmacists and technicians understand their patient safety responsibilities. Then there's ISMP, the Institute for Safe Medication Practices. ISMP offers reports periodically. They have a newsletter with tips, with ideas on how to promote medication safety. And then they have a medication safety self-assessment that's available online. By all means, avail yourselves of this. It's an excellent tool that can be used by pharmacists to evaluate their system at their pharmacy and understand where it is that they may have some work to do in meeting patient safety goals. Boards of pharmacy are involved as well, and we'll get to them a little bit later. Corporate risk management looks a lot like patient safety, but in fact is different. Corporate risk management has as its purpose the prevention of financial loss due to liability. It's not intended to comply with regulations or to improve patient safety. The idea behind corporate risk management is when a mistake is made, the company can be sued and will have to pay money. And so the purpose of risk management is to reduce the likelihood that those funds will have to be transferred to someone outside the corporation. Within corporate risk management, oftentimes pharmacists and technicians are viewed as the problem rather than as the solution. Pharmacists and technicians make mistakes and expose the corporation to financial loss, rather than within patient safety, where pharmacists and technicians are viewed as a solution, people who can implement systems that will reduce the incidence of medication errors. Within corporate risk management, the approach oftentimes is to develop rules rather than change systems. Rules that say, do this, check that, do this, don't do that. Rules that say, if you're going to work as a pharmacist or a technician in our pharmacy, you must do these things that we think will make it less likely for you to make a mistake. Now, patient safety instead focuses on the system and decides what can we do to reorganize the way we're providing care to patients. Corporate risk management generally doesn't do that. Instead, they pronounce edicts and say, this is what you must do, the idea being that if only the pharmacists and technicians would pay more attention and do their job better, we at the corporate level wouldn't have these problems. And then another aspect of corporate risk management is that there's the silo effect. It ignores positive incidents where change is made after a communication with a prescriber or a patient. Now, patient safety doesn't ignore that, and it's important. Every time a pharmacist calls a physician or other prescriber, and as a result of that call, a change is made, that's a positive incident. Every time a pharmacist talks with the patient and provides information about medication use resulting in a change by the patient for the better and how they're using medication, that's a positive incident. We're losing those. We're not keeping track of those. So when people say to us one of these days, justify your existence, we won't have those data to provide as evidence of why we're such valued people. And corporate risk management doesn't really require that that be done. Patient safety programs do, but corporate risk management doesn't. Corporate risk management focuses on the negative incidents rather than the positive incidents. Now, the media has caught on to error in pharmacy. You may have seen some of these headlines. I certainly have, and I'm often taken aback by them. The unfairness of them is dramatic. Just the pointlessness of them is amazing to me. Danger at the drugstore, prescription for disaster, deadly drugs. Can you trust your pharmacist? I mean, these are all actual headlines of stories that are told about mistakes that have happened and people who have been harmed because of those mistakes. And I understand it attracts readers. Attracting readers sells advertising, and that's what the media are about. They're about selling advertising more than anything else. That's what they want to do, and I get that. But still, it's sort of unsettling that this relationship of trust that pharmacists have with patients is diminished by the media that inaccurately report stories that have messages that, at least in my view, are way overblown. Who is that behind the prescription counter? That's a story I saw a few years ago that, surprise, surprise, disclosed to readers that there are pharmacy technicians who are behind the prescription counter. Not all of those people behind the prescription counter are pharmacists. And in fact, sometimes you can't know who it is that's behind the counter. Well, there's a point there. And in order to address that point, it's probably a good regulatory strategy to have ID badges so that if you're looking at someone, you can read their ID badge and see that that person is a pharmacist or that that person is a pharmacy technician, rather than wondering who on earth is this. And then there are a couple of stories that I think probably do have some value. Protect yourself from pharmacy error, and if in doubt, ask. Suggest to patients that they have some responsibility too. Simply cannot just sit back patiently, as patients oftentimes do. I don't like the word patient because it suggests inactivity. It suggests irresponsibility, uninvolvement. And what these stories have said is, patients, it's possible that errors will occur in pharmacies. And in order to protect yourself from that, here's some things that you can do to lower the risk for yourself rather than expecting everyone else to take responsibility for you. So let's take a look at the problem. Let's see if we can figure out what it is that needs to be solved. And in this slide, what I have done is I've presented for you the data from the 2013 Pharmacist Liability, a 10-year analysis that was posted by CNA, the insurance company, CNA. And I commend you to Google that and get your own copy of it. It's about 75 pages long, has a lot of really good information in it, has some suggestions of things that can be done, and we'll look at a couple of those and ask ourselves whether they make good sense for us. But for our purposes right now, what we need to do is just look at the types of claims that they report having been made over a 10-year period. Now, bear in mind, these are legal claims. So the data are somewhat skewed in that these are errors that were recognized by patients that led them to sue their pharmacist. And it may be that if one were instead to look at the errors that actually occurred, they would tell a different story than this slide does, because it may be that errors and claims aren't exactly the same. Nevertheless, this is what we have. You have to figure these are the important ones. If a patient was willing to subject himself or herself to this nasty legal system we have, it must be that there was a good reason for it. And what we can see from the offering provided to us by CNA is that there are really what I consider to be, and I did this myself, I divide these errors into mechanical errors and intellectual errors, skill errors and knowledge errors. Mechanical errors are what you do with your hands. Intellectual errors are what you do with your head. So let's take a look at these, and I'll read them. I know you can read them yourselves. You've probably already done it. Wrong drug, 43.8%. Wrong dose, 31.5% of all claims. Now, I will tell you, I looked at the report, couldn't really figure out to my satisfaction. I think what they mean here is wrong strength. Wrong strength. They have a category at the bottom called wrong strength, which I think means a solution that had the wrong strength of drug in it. Not that a solid oral dosage form was dispensed in the wrong strength. Wrong dose, a dose is a daily amount of medication. A strength is the amount that a single dosage unit has in it. And I think that these wrong dose errors are really wrong strength in that the pharmacist dispensed 2 milligram warfarin rather than 1 milligram warfarin. That's not a wrong dose error, that's a wrong strength error. Compounding miscalculation, 3.7%. Wrong dosage form, 2.5%. Improper substitution, 1.9%. Drug contamination, 0.6%, and wrong strength, 0.6%. Then over on intellectual error, failure to contact prescriber, 4.9. Overdosage, 3.1. Wrong patient, 3.1. Wrong patient in the sense that Mr. Jones shows up and says, I'm ready to pick up my medicine, please, and gets the medication for Mr. Johnson rather than Mr. Jones. Drug allergy, 1.9%. Failure to counsel a patient, 1.2%. Drug-drug interaction, 0.6. No child-resistant closure, 0.6%. Okay, so there are the overall numbers. Now, what can we take home from this? What's the take-home message? I think the important take-home message is that just over 75% of the total claims against pharmacists, according to the CNA study, in the past 10 years are for wrong drug and wrong dose. There are a lot of other claims, a lot of other errors that occur, but there are two of them that stand out as occurring by far the most frequently. And that's both good news and bad news. It's bad news because it seems to happen so much. It's good news in the sense that it's not rocket science. We should be able to figure this out. The wrong drug and what I think is the wrong strength are two errors that we should be able to reduce fairly easily. And if we do, address those two errors, we're going to be addressing a high percent of the errors that are made. So I think a good strategy for a pharmacy regulatory specialist to take would be to start with the most prevalent problem first. After having addressed it, move on to the less frequently occurring problems. Now, intellectual error, as you look at that right-hand side, you see they don't happen that often, but something that's important about that is that they now comprise about 15% of all claims. And 20 years ago, it would have been close to 0%. So I think this slide tells us two very important things. First of all, mechanical errors, wrong drug, wrong dose/strength, are by far the most frequent in pharmacy, and we should be able to figure out ways to deal with those. And that would be our first stop in addressing patient safety issues. But secondly, second issue is we're going to have to get a handle on these intellectual errors that are increasing very rapidly. And if we don't figure those out, then they could be far more prevalent in the future than they are today. Now, the CNA analysis provided some recommendations that I think are worth considering. These are not my recommendations. These are the recommendations that are offered in the 2013 Pharmacist Liability, a 10-year analysis as provided to us by CNA. So, for what it's worth from them, let's take a look at these. First of all, they suggest that error-prone drugs be made conspicuous, that something be done with these drugs so that attention is called to them, so that the sentinel shouts out, "Warning, warning, you're about to use an error-prone drug." And there are a variety of ways to do this. One way to do it is to use a sleeve, like that sleeve that Starbucks gives you on a cup of coffee that you put over the cup so it doesn't burn your hand. That sleeve or things like that can be used in pharmacy, placed on bottles of error-prone drugs, so that when a pharmacist or a technician retrieves one of those, that person says, I right now have in my hand one of these error-prone drugs, and I better think this through and make sure that this is what I want. A second recommendation that the CNA study makes is to challenge expectations. We tend to see what we expect to see rather than what's really there. And so what they're suggesting is that rather than keeping risky drugs on the shelf or in the drawer in exactly the same place they be rotated, the location be changed so that people who obtain them and intend to use them in dispensing have to think, where is that? Rather than getting in automatic mode and reaching for something that turns out to be the wrong thing. A third point that they make is, don't over-rely on technology. Don't assume that since the technology is doing it, it must be doing it right. Keep those checks in place, those physical, manual, visual checks in place, so that technology, if it does happen to have a glitch, can be caught and the problem repaired in time before harm is caused to a patient. And then, fourthly, you'll love this fourth bullet, there has to be an appropriate workload. Of course, pharmacists have been saying this for years and years and years. The point they make is that it shouldn't be too much, but it also shouldn't be too little. And what they note in their report is that correlates of error are both high workload and low workload. Apparently, where the workload is too low, there is a tendency not to pay attention because there's not enough to do. So workload is an issue they suggest attention be paid to. something that's pretty much automatic for anybody who's been around pharmacy for any length of time. Fifthly, they say recognize individual capabilities. And I think this is an important recommendation that's worthy of some consideration. Some pharmacists and some technicians need a lot of breaks. Others don't. Some pharmacists and some technicians appreciate having a very orderly workplace. Others don't need that and don't want it even. So what's important, the takeaway for me from this recommendation that CNA offers, is that workplaces should be flexible enough to be individualized to the unique needs of pharmacists, pharmacy technicians, and in fact the team that's working on a given day. It may be that that team works particularly well in a certain fashion that isn't conducive to success for another team, but let them do it their way and give them resources so they can do it in a way that's successful for them. And then lastly, the recommendation is remove impediments to attention. There are system impediments to attention. There are distractions. There's disorder, chaos, lack of support, lack of management support. And those impediments to attention, they suggest, should be removed. But there are also personal impediments to attention. Illness, fatigue, not being up to date. These are things that can be addressed by regulatory specialists who are in a position to understand that there are system problems and personal problems that serve as impediments to attention and have to be removed. So, what have boards of pharmacy done? How have they responded to this problem of error? They've not done it consistently, and that's fine. Boards of pharmacy differ in their needs and wants and approaches, and different states vary in the appropriate ways to address problems. But basically what we have is three possible ways for boards of pharmacy to address the problem of pharmacy error. One is to do nothing, the second is through punishment, and the third is quality improvement. So let's talk for a minute about doing nothing. Some state boards of pharmacy feel that they lack clear authority to do anything about pharmacy error, that their State Pharmacy Practice Act doesn't authorize them to address error. Yes, if a pharmacy doesn't have enough graduate cylinders, if the pharmacy doesn't have enough tablet counters, enough counting trays, if they don't have enough spatulas, that's a problem. Yes, if the pharmacists aren't doing their CEs, we can do something about that. If the pharmacy doesn't have a sink and running water, then we can address that as well. But if they're making mistakes, there's nothing we can do because our Pharmacy Practice Act doesn't clearly tell us that there is something we can do. Now, another approach that falls within doing nothing is just to let the market handle it. Let the community handle it through word of mouth. Eventually, the word will get around that this is an unsafe pharmacy and that you should take your business elsewhere. So there's really no need for the Board of Pharmacy to intervene and do anything because the market will operate efficiently to inform people of where the safe pharmacies are and where the unsafe pharmacies are. And then there's a third point of view, which is let the lawyers handle it. If a pharmacist makes a mistake, if a pharmacy technician makes a mistake, then the patient who's harmed by the mistake can go to a lawyer and sue the pharmacy, and they'll likely recover money damages against the pharmacy or against the pharmacist. And that, according to some boards of pharmacy, is an appropriate way to manage error. Other boards of pharmacy take a different view, and they have decided that for them, punishment is an effective approach, an effective response to error. Some of them have a wait for a complaint and punish approach. Some of them have a require a report and punish. In other words, require the pharmacist to report an error, and the pharmacist then gets punished for having made the error. So these are two separate there's two alternatives to punishment. One of them being wait for a consumer complaint and then punish the pharmacist when it's verified that an error occurred. And the other is to require that the pharmacist report it and then be punished. A third approach is quality improvement. Quality improvement stresses individual factors and system factors. Individuals, technicians and pharmacists are part of the system. So in quality improvement, we try to improve not just the quality of the system, but the quality of the individuals within the system as well. The system sets good pharmacists and technicians up to fail, but no system can be so good that an incompetent pharmacist or incompetent technician can practice within it and not make mistakes. Now, there are two different ways for quality improvement rules to be used. One is for them to be mandatory. You must use quality improvement within your pharmacy. The other is to have it as a mitigating factor so that pharmacies aren't required to use quality improvement programs, but if an error happens and a complaint is made to the Board of Pharmacy and it is shown that they had a quality improvement system, then the Board of Pharmacy will be more tolerant toward the erring pharmacy than they would otherwise have been. So what are some problems with these two approaches? What are some problems with punishment? What are some problems with quality improvement? Neither of these two ways is fully effective. Problems with punishment are the blame and shame, or blame and retrain, that they bring. They focus attention on a particular individual, concluding, you're the one who's at fault here, ignoring the system. Blame and retrain is based on the idea that if you have a pharmacist who's making a number of errors, you can take that person, spend a weekend or a week or whatever retraining that person on how to do his or her job better, and then put that person back in the same system that was causing the problems to begin with. Another issue with punishment is cover-ups. If you're going to punish somebody for having made a mistake, then there is a disincentive for them to admit those mistakes, to record those mistakes, and in fact, there is an incentive for them to cover up mistakes. Another problem with punishment is it's reactive rather than proactive. It occurs after the harm has already happened. It doesn't prevent harm. It reacts to harm that has occurred. Quality improvement has its problems as well. Quality improvement can be gamed. You can make a game of quality improvement and pretend to be engaged in quality improvement activities when in fact you're just playing around. It requires strong leadership. And unfortunately, pharmacy is no different from any other profession. We have a lack of strong leaders. And another problem with quality improvement is that it relies on making records of incidents that can later be studied to determine what it was about the system that caused the error to occur. And in making these records, if they're not protected from discovery, they can be used later as evidence of negligence. So you're slitting your own throat to do quality improvement, to make records of your past failures if you're just going to have to turn these records over to somebody, to a lawyer, who's going to sue you. And for that reason, in states where quality improvement is done well, there is protection from discovery that's afforded to these records, which are called peer review records. So what have the pharmacy self-regulators done? What has the Board of Pharmacy done in many states? Well, in order to move to continuous quality improvement, they have undertaken several important steps. First of all, they establish a rule that requires or recommends CQI. They either require it, it's mandatory, or it's recommended and it's considered a mitigating factor in discipline. But what pharmacists have a right to know is, what is it that you want us to do? And the way that is explained is through the promulgation of a rule. The second step that states that do this undertake is to train their inspectors as educators. So the inspectors can go out to the pharmacies and help the pharmacies understand what the expectation is of them to perform continuous quality improvement. The third thing they do is they allow a grace period prior to the enforcement of the CQI rule. There's a period of time, and they'll announce that. They'll say it's 6 months, 12 months, 2 years, whatever. During this time, what we expect you to do is begin to implement your CQI program, and we're going to work with you to make that easier for you to do, and only after the expiration of this time will we begin to enforce the rule that requires that you do it. Then what they do is they inspect pharmacies and they respond to complaints. So either through an inspection, where an inspector sees that CQI isn't being done, or as the result of a complaint by a patient who says an error occurred, a pharmacist, or a pharmacist in charge, will be called before the board and asked to show some evidence of things that are happening. Now, the Board of Pharmacy is going to be relatively tolerant, relatively forgiving of people who are conducting CQI meaningfully, but who nevertheless make an inadvertent error, and relatively intolerant, relatively unforgiving of those who aren't even trying to prevent errors. So what do they want to know? First of all, they say, show us the evidence that your CQI program was operating at the time this error occurred. We just want to see your policy and procedures manual. We just want to see some records indicating that you meet periodically to talk about errors. We just want to see some evidence that you're actually doing this rather than just pretending to do it. We also want to see the evidence that you mitigated the error, this specific error, this specific incident, once it was discovered. What did you do? Did you call the doctor? Did you talk to the patient? We just want to make sure that you did everything you could to mitigate the potential negative consequences of this error once you discovered it happened. And lastly, we want you to show us evidence that the error was incorporated into your CQI program. Now, pharmacists will either be able to provide that evidence or they won't. And a lot of it depends on their ability to show that they were trying to prevent errors from happening, as opposed to not even caring whether errors occurred. So how can a pharmacy regulatory specialist comply with the CQI rule if you're in a state where the Board of Pharmacy, the self-regulating Board of Pharmacy, has decided this is the direction we want to take? Well, I think there are several important steps. First of all, there has to be corporate buy-in. There's no sense in even trying if you can't get that. If you can't get managers to agree that this is something that needs to be done, then take your efforts elsewhere within the pharmacy system and try to improve as best you can some other area of pharmacy practice, controlled substances, for example, or some other aspect of what's being done. If corporate doesn't buy into this idea that CQI compliance is important, then don't even try. Hopefully, you'll be persuasive enough that they will buy in. After they have, meet with pharmacy leaders. Pharmacy leaders throughout the pharmacy system you work in, or maybe if it's in an independent pharmacy, just a small group of people who are the people who really accept responsibility for the quality of what's done. Then you have to design a system to meet the needs of staff. That means including everyone in this process. Rather than saying, I'm the pharmacy regulatory specialist, I'm going to tell you what you're going to do. You convene a meeting. It doesn't take more than an afternoon. I've done this a number of times. And you say, let's talk about what it is that we can do together to design a system that's going to meet your needs. Now, of course, once you've designed that system, you expect compliance with it. But you'll have ownership of it by everyone if they are included in the system design. Then you have to train the leaders or train the trainers. You have a number of leaders who are going to go out into the corporate world, the pharmacy community of which you're a part, and they're going to train everyone. Because eventually all the pharmacists all the technicians. Everyone needs to be trained in this. So you have to do training in the system that's been designed. Then there has to be resources necessary for success, and those you get from corporate through their buy-in. You develop policies and procedures, forms, checklists, and guidelines, and data analytics that can help people understand how well they're doing as opposed to how well they were doing previously. An important component of CQI is regular feedback. For example, through an electronic newsletter. People want to know, how am I doing, and what have you learned from others that might help me do my job better? The pharmacy regulatory specialist can also discuss the program with Board of Pharmacy staff and inspectors to make sure that it complies with the expectation. Well, at each local pharmacy, what they have to do is select a quality team leader, a single person who's responsible for quality in that pharmacy. When you walk into a pharmacy and say who's responsible for quality, there should be one person who raises her or his hand. If nobody raises their hand, you got a problem. If everybody raises their hand, you got a problem, because you can't have everybody be in charge. One person has to have that responsibility. It could be the pharmacy regulatory specialist who accepts that responsibility, or it could be another person who's doing it in collaboration with the PRS. You have to, at each pharmacy, adopt the definition of incident or quality-related event. This may be adopted from some sort of corporate definition or an academic person's definition or the State Board of Pharmacy, but at each pharmacy it has to be defined. What is an incident or quality-related event? You describe steps in the practice process. At this pharmacy, here's how we're going to do what we do. From receiving the prescription to delivery to the patient, everything that goes on in between is an event and is an opportunity for an error. And we want to define what those steps are, what those stations are in pharmacy practice, so that we can better understand where it is that an error occurred and go there to correct the system to prevent future errors. You have to develop a QRE recording system, not reporting system, but recording system. And hopefully that will be computerized. So when a quality-related event, an incident, or a quality-related event occurs, you can record it and put as much information as you know about it into the computer or on the piece of paper at that time. The blanks can be filled in later. Then you have to train staff in the QRE responsibilities. That's where the trainers part comes in. Then you begin the program. You just start it. You just have to do it. At some point, the planning stops and the acting starts. And then you have to periodically assess the progress with positive reinforcement, meeting with everyone, thanking them for having done such a good job, congratulating them on their success, and asking them, what else do we need to do in order to improve? Now, when an error occurs, and errors are inevitable, it's important that they be addressed in an appropriate way. When patients come in and say, you made a mistake with my prescription, it's never a good time. It's always the busiest time of day. There are other things that are happening that require attention, so you can pretty much assume that an error report is going to arise at a terrible time. So you have to have a plan. You have to have a plan of how to address this. The first part of a plan is that this is a pharmacist-only issue. Pharmacy technicians don't talk to patients about errors that they're complaining of. Non-pharmacist managers don't talk to patients about errors that they're complaining of. Now, it's perfectly fine for a non-pharmacist manager or a technician to say, the pharmacist will be right with you. She's busy right now. Can I get you a cup of coffee? Please sit here. I'd like to make you comfortable while you wait. But discussing the error is something only a pharmacist does, and that's done in a private place. Find a private place. Plan for it. Where are you going to go privately so you don't have a dozen or so people watching? And role play. Role play how to effectively manage the error complaint that comes to you. Above all, it's important when a patient complains about an error to listen carefully, to stop talking to the patient and listen to the patient and find out what it is that they're complaining about. It may be that there wasn't an error, but you're only going to discover that if you listen carefully. Offer a safe apology. I am sorry. You don't have to say, I am sorry, we really got sloppy, we were rushed today, I don't know what happened. Don't say that. Just say, I am sorry. Apologize for the confusion. I'm sorry for the confusion. I'm sorry that you're distressed, but at least say, I am sorry. Explain what you know. Explain what you know about the situation. At that point, the patient has a right to know what you know. But don't speculate. Don't guess. And certainly don't accuse anyone. Don't say that floater pharmacist must have made a mistake. You don't know that. It's irrelevant. Move on. Promise the patient that improvements will be made. Rectify the error, obviously. If the patient got the wrong drug, then fill the prescription correctly. And promise them that improvements will be made. And follow up and conduct CQI so that those improvements become a reality. So how do we sum up? Well, human error is inevitable. We can't not make errors because we're humans. Systems set up humans to make mistakes. We know that. The regulatory challenge is to find a safe harbor for those whose mistakes were made despite the best efforts to prevent them, as opposed to those whose mistakes resulted from no effort at prevention. This is a hard sell to many pharmacies, and it has to be made by a local person who is trusted, and that's probably you, the pharmacy regulatory specialist. And the last thing we know is patient safety helps everyone. Patient safety is good for patients, it's good for prescribers, it's good for pharmaceutical manufacturers, it's good for pharmacies, for pharmacists, and pharmacy technicians. So it should be a no-brainer if it's approached in a trusting way.